So now that we've looked at types of seizures and their causes, as well as what nursing assessments we need to perform, let's look at therapeutic management for patients with seizures. The first thing we'll see is our diagnostic testing. Now, seizures are diagnosed and named based on their clinical signs so that we know what type they are. So we need to look at those things in particular. But beyond that, we're going to perform something called an electroencephalogram or an EEG. Now, this is something that's set up and managed typically by a technician with special training, but we want you to know what it looks like and what the purpose is. So to perform an EEG, the patient will get dozens of electrodes put onto their head. Sometimes it's in a cap. Sometimes they're physically placed by that technician. And the purpose here is to get multiple waveforms to measure brainwave activity. And so we get this readout that looks like this, and it actually can show us when the patient begins to have a seizure. Again, seizures are this overreaction of these nerves. So you can see how these spikes get taller and how much faster they're going, and they're overreactive. So an EEG can tell us not only the fact that there's having a seizure, but also what types of brainwaves we're seeing, where the seizures are occurring or where they're originating in the brain, and how severe they are. Now, a lot of times patients will actually be placed on continuous EEG for 24 hours or more so that we can actually try to catch a seizure on the tracing so that we can get this information that we need. Now, when we talk about medications for seizures, we're talking about AEDs or anti-epileptic drugs. Now, there's two sets of drugs that we're going to give to patients who are having seizures. One set is to stop seizures when they're happening, and the other set is to prevent them or be maintenance medication for prevention. So the first line drug for seizures when they're occurring is benzodiazepines. Specifically, lorazepam or Ativan is our first line drug. So when a patient begins to have a seizure, we're going to give 1 to 2 milligrams of Ativan IV push as soon as possible to try to stop or break that seizure. Now, we could also use diazepam or Valium, which is actually commonly used rectally in home care. So people who have seizures at home will have rectal Valium available to deal with that since they won't have regular IV access. Now, for patients in status epilepticus that doesn't break with a benzodiazepine, we'll move on to barbiturates. And the most common one that we'll see is phenobarbital. And a lot of times we'll actually put them into what's called a phenobarb coma. So we're completely trying to cancel out all brainwave activity to get that seizure to stop. Now, once we've stabilized the patient, we've stopped the seizures, we're going to be putting them on these maintenance medications. The most common of which that you'll see are going to be Dilantin and Keppra. Now, the other two that you might see are fosphenytoin and lacosamide, which is Cerebex or Vimpat. The choice of which one of these we give to the patient is really just dependent on the provider that you have. But the most important thing that you need to understand is that they're going to be taking these medications for the rest of their lives. They have a very short half-life, which means you need to make sure that you're giving them at the right time. Timing is very important. Patients can have seizures just by missing one dose of medication or by if the medication is late by an hour. So we need to make sure that we're giving their medications on time, that we're teaching the patient how important it is to be compliant. The only other thing to note is that Dilantin actually has very narrow therapeutic window. So we're actually going to be assessing therapeutic levels with Dilantin as well. But honestly, Dilantin is not given as commonly these days. Usually you're going to see Keppra and you might see some fosphenytoin. Now, there's a few procedural options for patients who have frequent seizures, although it's pretty rare to actually see this happen. But ultimately, if we do them, the goal is to either remove the overactive neurons or redirect them so that they don't overstimulate that electrical activity. So one of the options is a lesionectomy, where they actually remove the portion of the brain that's causing the overaction or the overactivity. The other option is a neurotomy, which is where they actually cut the nerves that are giving those excessive nerve impulses, and that the goal is to stop that impulse from traveling. And then we can also see something called deep brain stimulation, where electrodes are actually placed in the brain to stimulate the portion of the brain that's causing the problems, with the hope that they can actually distract or redirect that electrical activity. Again, these are relatively uncommon, but you may come across a patient who has had one or more of these. And deep brain stimulation is newer and it's becoming more and more popular. So let's recap. In order to get an effective diagnosis, we need to get an EEG or an electroencephalogram. Again, the EEG tech will take care of the setup and everything, but if we notice that any of the electrodes or the wires have dislodged, definitely notify the technician to come back and fix that setup. Now we have our rescue meds. That's our benzodiazepines. So the most common thing we'll give is Ativan 1 to 2 milligrams IV push. Now, if it's allowed by your facility, it is good practice to have Ativan locked up at the bedside for easy access instead of having to go get it out of the med room. But if that's not allowed at your facility, at least make sure that the patient has a PRN order for Ativan. The last thing that you want is to be having to call the doctor for an order when the patient starts to have a seizure. So at least if you have a PRN order, you can get it out of the med room. Now, then we'll also make sure that these patients are getting their maintenance meds like Keppra or Dilantin, getting them on time, making sure they're being compliant with them, and that we're monitoring therapeutic levels if applicable. And then finally, remember that these procedures are relatively rare, but they're going to come with some of the same post-op precautions as really any other craniotomy. So make sure you check out the nursing care lesson within this module to learn more about specific nursing interventions. And that's where you'll also find a care plan and a case study for a patient with seizures. We love you guys. We hope you're really getting the big picture of taking care of a seizure patient. Now go out and be your absolute best selves today. And as always, happy nursing.